Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. My name is Aebhric. Today, I am with Dr. Edit Gara. Dr. Gara is a MD PhD, and she is based in Budapest. Hello, Edit. How are things?
Hi, Aebhric. Thanks. Very good. And thanks for having me back on this great program. It's always a great pleasure for me to talk to you.
Today, you wanted to talk about pediatrics, specifically with burns.
Yes. So I wanted to continue with the pediatric topics. And today I brought burns, which is a really complex topic. And also I think it's crucial to talk through a bit because unfortunately burns and burn disease takes up a huge slice in the pie of morbidity and mortality in the pediatric population in emergency situations.
Are you seeing a lot of burn pediatrics in your clinic?
So with the ambulance, unfortunately, quite a lot burns. I've just seen in the literature that burns is the leading cause of death between the age of 1 to 9 in the pediatric population.
Wow.
So unfortunately, it's really high number. And small burns happens almost every day, but here we are talking about the really severe burns, which causes a complex disease in the whole body, which is so-called a burn disease. We will talk through this today.
So what are the main causes you're seeing in pediatric burns?
Yeah, so I wanted to mention this, and this is a really good question because frequently a burn is combined with a trauma. So roughly you can count with trauma when you are called to a burn patient. It's not always the case, but many times. For example, an explosion or a car accident or whatever is the cause of the burn itself. But not the car accident is the most frequent cause of the burn itself. Rather, the boiling water and those accidents in the kitchen. Those are the major causes behind burns, and then comes a direct burn in a flame, then comes some chemical or electrical burns, which happens by accident, and some novel ones, for example, too hot milk from the microwave. It can also cause some severe burns. So it's in the literature that there were cases with too hot milk from the microwave with pediatric population. So really careful in the kitchen. That's the leading cause of burns, kitchen accidents.
So the pediatric patient is what, reaching up to a boiling kettle or boiling to
yes,
pulling...
that's right. Or they just simply run over and hit the parents, and they just fall, or just the kettle is just falling out of the hands. So it's really a place for a severe accident, the kitchen. So really careful.
So let's talk about that as one of the main causes. So you have someone who just got a scalding burn from a hot water. How do you cool the burn? Yeah,
so thanks for this question, because as the first physician, first medic there, our major task is to cool the burn because that just helps to relieve the pain and also helps to slighten, to make smaller the area affected, and of course to make to not to have so severe side effects and so severe stress reaction from the whole body, which is resulting in a systemic burn disease. So how to cool? First thing first, fortunately, many parents, they do kind of by heart that they put the child under cold water and they just let the cold pouring water onto the wound, and that's the thing they want to do, and you can also do as a physician or as a medic It's really important to outline that hypothermia makes the whole burn disease even more severe. So you don't want to have a child with a burn disease being hypothermic. So be careful with cooling too much. And of course, as medics, we have very good medications and also very good instruments around us. So hopefully we have the bandage, which is good for the burned wound. For example, there's one which is called water gel. There are many on the market. So it's like a jelly bandage, really has a cooling effect, painkiller effect, and you can directly put it onto the wound, the burned wound. So that's what I suggest as a physician. If you have this with you, use that. Never use ice, never ever, because that is just too much and too cold. And so, coming back to my practice, that's we've seen many times that parents, they want to do good, and they put, for example, a 1-year-old baby severe burn on a huge part of the body, and they put the child into the bath and just let the cold water just pour on that poor child, which is good for the wound, but not good for the whole body. And we just found them severely hypothermic. So try to avoid it. And if you can put the water gel on all wounds you find, but if you don't have that, or if you need to use the water, then try to cool only 20% of the body. And if you have larger amount of wounds, then just do for 10 minutes 20%, and then in the next 10 minutes do another 20%. So don't overcool the child. That's really important in a pediatric burn.
So it's important for adults, but it seems like it'd be even more so for the pediatric patient, wouldn't it?
Yes, because the hypothermia is even more severe in pediatrics, and it's once in hypothermia, so it's not so easy to return. And of course, when you've just done with the water gel, with the bandage, then you can put a blanket on or use an isolation blanket to avoid further hypothermia.
So how long would you put the child under tepid water to cool the burn?
15-20 minutes is enough.
Yeah, and only 20% of the body at a time.
Yes, that's important. And if you have more, unfortunately, very severe burns, then you can go to another 20%.
And whilst you're doing that, you can wrap the patient, the pediatric patient, in a blanket or something to keep the rest.
Or a towel, or whatever you find. And it's important, even in the first minutes, to try to estimate how much part of the body is affected. Because if there's a severe burn, which means that 20% or more of the body is affected, then you have to count with the burn disease and with the systemic response.
So there are many ways to calculate the total burn surface area. What is your favorite?
So there are many, and it's not easy to calculate in the pediatrics because their body, the anatomy, and they are different than adults. We know the rule number 9, which is good for estimating the burn in adults, which means that an arm is 9%, a leg is 2 times 9, so 18. The head is around 9, and the thorax is around 4 times 9, and the back is again. So, but this number 9, which is also called the Wallace rule, this is not working in pediatric. In pediatric, I would suggest there are many kinds to calculate, many ways, but I suggest one which is really practical and you can easily use at the scene in pre-hospital or even in rural situations as well. So roughly the size of the palm of the child, that counts 1%. And then by that, you can, if the child is cooperative, you can even try to put the hand there and try to estimate how big is the burn. So you would like to estimate the percentage of the whole body surface area, BSA. So the palm is 1%, and by that you can estimate 20% or more really severe case.
So you're using the patient's palm and not the fingers, just the palm, and that's each one of those is 1%.
Yes, that's right. That's right.
So once you've calculated the burn surface area, how do you use that for your hydration therapy?
So in treating a child with burn, the most important that you can do is to start the volume therapy early. If you have a severe burn, you can start with 20 milliliters per kilogram. So it's easy to remember, and it's also a good estimate to start fluid. Yes, I can say resuscitation because they are in a severe case. And we also have a rule how to calculate the amount of fluids to be given in the first 24 hours. So usually when you are in a city or you have around hospitals available for child with burn, you only spend the first couple of hours or just the first hour with the child. But in remote conditions, it's important to know how to administer and how much fluid to administer the first 24 hours. And for that, we have another rule, which is called the Parkland rule. This you can calculate the amounts of fluid, which is 2 to 4 milliliters per kilograms pro the amount of burns on the whole body surface area. So 2 to 4 multiplied with weight and multiplied by the amount of burn. And this gives you a number which is the amount of fluid for the first 24 hours. And the half of this should be administered in the first 8 hours after the burn, and the rest is in the next 16 hours. It's a bit complex and complicated, but there's also another practical tool for your help. If you can use a urinary catheter and the patient might be intubated and with painkillers, so in a really severe condition, you can even use a urinary cath. And with that, you can watch for the urinary output, and it should be 1 to 2 milliliters per kilograms per hours. So that's a good way to double check the amount of fluids given, that you have a good urinary output.
Could you use POCUS ultrasound to look at the IVC for fluid status?
Yeah. That's very good, and that's not something which is in the burn guidelines. So it's not, but it's a great idea. And if you have the ultrasound around and you have experience, then good field IVC is what you are aiming. Yeah, that's a great idea. Thanks for that.
And what fluids do you suggest?
Yeah, just crystalloids, saline. So never use colloids or gelatin or whatever in the pediatric burns, because those just makes the capillary leakage even more severe, makes the burn wounds themselves even more severe. So never use colloids, just clear crystalloid fluids.
If you had fresh frozen plasma, would you suggest that?
No, not really. So not in the first medical care. So the burn disease itself is just a vicious circle, and for a pediatric, I would estimate that they never received any blood product. So that could just make the vicious circle even more severe. So I would not suggest fresh frozen plasma in the first 24 hours. Of course, later on and in the hospital care, if they have experience and if they with the diagnostics they see that would help, then yes, later on it's something to try.
So you've mentioned a couple times the generalized Burns disease. Can you give us a background of what exactly is that and what's the pathophysiology of generalized burn disease?
Yes. So with the burn itself from the wounds, there are many vasoactive agents which are just released. And first they are released locally, and they are just making those. We've all seen those terrible wounds which are really leaking or even really white and pale, and so it's just a disaster. So there's a local reaction, which if it's over 20% on the whole body, then it's immediately affecting the whole system. And these vasoactive agents just they act on the capillaries, on the all capillaries in the body, and they make them leak. So there's a capillary leakage. The capillary permeability is increased, and this is resulting in an extravasation. So there is a tendency for becoming edemas on several parts of the body, also peripheral edema, and not just on the affected, the wound, the burn affected parts of the body, but other parts as well. And also there is a risk for pulmonary edema for the same reason. And so, as I just mentioned, this is a vicious circle. It is leading up to a bit of decreased immune system reaction. You can imagine they are intubated on an ICU. It's a whole complex treatment, and they get just really prone to sepsis. And unfortunately, when it's an extremely severe condition, mostly they die from sepsis because just this whole burn disease it's just self-accelerating. Also, there's I wanted to mention that there's it's again a practical tool to try to calculate the risk of death, which is you have to add the age and the percentage of the burn, and if it adds up above 90, then it's almost 100% that it will be unfortunately a fatal case. If it's over 70, then it's a really high risk of a severe outcome in death. So imagine there's a 1-year child, 80% of the body is burned, so that's 81. So that's really low chance of survival, unfortunately.
Wow. So generalized burn disease causes the leaky vessels, causes pulmonary edema. And plus, on top of that, we're giving aggressive hydration, which can also cause pulmonary edema.
Yes. Thanks for mentioning this. I also wanted to touch on that very important to give the fluids, but also really important not to overload or try to avoid overloading with the fluid. So as early as you can monitor the urinary output, that's the best way to drive the fluid intake.
Can you give drugs to treat that for a pediatric patient? Would you give furosemide to drain the lungs?
Of course, you have to treat if there's a pulmonary edema. But yeah, like again, I would wait with that unless it's again, you can use your ultrasound if around, and if you spend 12, 24 hours with the burn patient, then you try to use all of your equipment to optimize the care. And if you see with your ultrasound that it's possibly true pulmonary edema, then yes, you can try. But I would try to avoid, again, in the first 24 hours, because if it's not a, of course, if you can't really keep oxygenized and hypoxic, and you have physical signs of pulmonary edema and no other ways to keep up with the ventilation and oxygenation, then you can try. But you can do more. You can do a lot of harm with giving furosemide if not needed.
So speaking of drugs, what else can we do? So we have capillary leakage. Would epinephrine be useful?
So if there's a sepsis, and if it's if the patient is in good volume and status, and still not good blood pressure, and so that if there's a septic shock around, then yes, you have to use the inotropes. You can give noradrenaline. Even in the last remaining option, adrenaline as well. I don't see a cause to give dopamine or dobutamine. No cardiac involvement. So my choice would be noradrenaline or epinephrine first line.
So speaking of drugs, let's talk about pains and sedation. What options would you suggest for giving pain in hospital? We'll start with in hospital first.
So the painkillers are again crucial for these children. It's unbearable, of course, pain. You have to, so to say, you have to hit hard. So you can use the ketamine. You can use nalbuphine. It's a very good opioid in pediatric, nalbuphine. Or you can use morphine if you have that and available. And also you can use fentanyl. So I would suggest these for painkillers. Ketamine is also sedative drug. You can use midazolam as well, so or propofol, or what is available for you. So there's nothing really special or no unique sedative for the burn.
So would you mix the midazolam with morphine or midazolam with ketamine to have a better effect?
Just and to avoid, ketamine is it's a tricky one, and it has severe side effects with horroristic dreams and very bad awakening from the hypnosis itself. So that's really recommended in the pediatrics to try to avoid that side effect. So yes, you can use both and mix, and of course keep an eye on the blood pressure. Try to optimize.
So speaking of drugs again, let's talk about antibiotics. What are your suggestions?
So in the first 24 hours, maybe you can wait. So even in pediatrics, antibiotics also they have tons of side effects when given IV. They are they depressive on the renal function, even on the blood pressure. If there's no true signs of sepsis, then you can wait, and further on, like following the protocol of the hospital, use a wide spectrum antibiotic, which is normally used on pediatric ICUs. But again, I wouldn't recommend in the first line medical care to administer antibiotics.
Speaking pre-hospitally, and you've worked pre-hospital quite a bit on the helicopter as well as the ambulance.
Yes.
Is your treatment changed at all, or are you going to use the same drugs and the same? Like, how would you cool the burn on an ambulance?
So changed in terms of pediatric and adults, or
no? We're just pediatric burns. You're on the HEMS helicopter. You arrive. What drugs? Would you use the same drugs options that we just talked about? Would you cool the burn.
So
And
I would use the water gel, so the specific bandage to cool the wound. So I would avoid the water, cold water, and just use the isolation blanket and some towels to avoid further hypothermia. I would intubate if needed with an rapid sequence induction protocol. Use midazolam and ketamine and nalbuphine for the induction and for painkiller. And it's important to transport the child to a center which has some experience with pediatric burns because it's on the longer term, it can be tricky, and it's good if they have a team to treat the wounds, a very good team to treat the general burn disease, very good pediatric ICU. So I would look for a place which has a good experience in treating pediatric burns.
that's the advantage of HIMSS, isn't it? You can
Yes.
go directly to the pediatric center.
Yes, that's right.
So you mentioned RSI, and burns were very fastidious about front of an access, the surgical airway. How would you approach that inhalation burn with a pediatric patient?
So thanks for mentioning this. So if you have a severe burned child, you have to look for signs of an airway burn or the affection of airway in any ways. For example, if there's a chemical burn, those gases can be really irritative. Even those irritative gases can result or can trigger a pulmonary edema. If there's a huge explosion, the heat itself can affect the airways. So you have to look for signs of any airway affection. How you do that? If the face is affected, wound, burn on the face, sunburn in the nose or the nostrils, burn on the mouth, they are suggestive of airway affection. Also, if there's a sound of stridor, when you do the physical examination, you have to estimate with a burned or affected airway. What you have to do is intubate as soon as possible. So that's my advice, and that's what HIMSS is doing in Hungary. So if there's any sign of airway affection, then don't wait. The protocol is really good. The child will be in good hands, and so intubate as soon as possible, earlier than later, because if the airways are affected, then in every second they just get a bit more edematic, and if it's just if you wait, then you and unfortunately the child will be in such a big trouble that the intubation will be really difficult or even impossible to perform. And then you have to look for other ways to secure the airway, which again, you are prepared to do that and trained to do that, but try to avoid, because even doing a surgical airway on a burned airway, or even if the neck is burned, you even struggle when you just have the scalpel in your hands if there's a burn on the neck. So it's extremely difficult. And of course, if you have to do it, then you try your best. But if any signs of airway affected, then electively with a really calm rapid sequence induction protocol, intubate as soon as possible. The child is treated well. They are sedated. They get the painkillers. The wounds are treated, and they don't have to kind of be around and experience that whole sequence of treatments and pain. So in general, an earlier intubation when the airway is affected, that's what you have to do.
Once you have that definitive airway, would you increase PEEP to push some of the fluids out of the lungs?
You can try again if the signs, the physical signs, and hypoxia are suggestive of pulmonary edema. Otherwise, just general PEEP, what you would otherwise use as well. So just as kind of proactively or to avoid the edema, I would not suggest the use of an increased PEEP.
For adults, having 5 PEEP is not much of a intervention. Is it different with pediatrics? Like a 5 PEEP is like a major step.
I would use like 2-3 millimeters of mercury PEEP for a pediatric. 5 is a bit high, yeah.
And then wrap them and transport.
Some unique conditions. Again, I mentioned the trauma. So if it's a trauma situation, then you use your trauma protocol and you add those which we just discussed. So that's a more complex case. For example, a road accident and with burning cars, and you have a polytraumatic child with burns. So you do the treatment of the wounds as well, try to give the good amounts of fluid and try to avoid hypothermia. So you kind of mix your trauma and burn protocol. Some other special condition could be these kind of chemical burns when really toxic gases are around. So you the medical team have to be really cautious, and it could be some time till you can reach the patient. Another tricky could be the carbon monoxide, which maybe can result if there's a dysfunctioning heater, which is causing a carbon monoxide toxication and finally explodes. That can lead to a burned child with carbon monoxide intoxication. So you have to think for these unique situations, and these can make your work even more complex.
That is a challenge, isn't it?
Yes, huge challenge.
What advice would you have for those working in extreme and austere environments that don't have water gel available, that don't have rapid evac like you have on the HEMS in Budapest?
Yes.
What suggestion would you have for cooling and covering the burn?
So for cooling, you can and covering, you can use a sterile bandage, which is not a specific burn bandage, but just a simple bandage, which is sterile if you have, and you can put on a bit cool, or if not cooled, then just normal saline, and you can put that on the bandage. That works as well. And once you put that on, then I wouldn't suggest to change that in the first 24 hours. If you have sterile, and there's a possibility to cool a bit of saline, a sterile saline, then you can pour that on the wounds a bit. That's helpful. And we've discussed the other steps needed in the first 24 hours.
And the urine output, you said, is pretty important.
So that's the most the best way to monitor the volumic status of the patient. So if you have a urinary cath in remote condition, then use it, and then it's a good way to monitor. And if you have 1 to 2 milliliters per kilogram per hour urinary output, then that means that the patient is in a good volume status.
So for some really small pediatrics, we use a urine catch where it's just like a bag that's taped on. Do you think that would be enough of a measurement, or do we really need to do the urinary catheter?
Yeah, for those really small babies, that's enough. Or that's not so. Not the best option to measure. but that's enough in a small population. And also, if you just have a nappy and it's wet in every 2 hours, then that shows that the baby has a good urinary output. So wet nappy in every 2 hours.
That's something I had never thought about. Thanks for that. That's a good indication.
Maybe you don't have this collection bag, and then you still have some really practical tool around to monitor the urinary output. If there's no nappy which is wet in like 3-4 hours, then I would be really worried.
That is a good assessment tool that we may have to add to the next field guide, because that's a fantastic bit of knowledge. Thanks for that. Mm-hmm. So thank you, Dr. Gara, for a deep dive into pediatric burns.
Thank you, Aebhric. It was really good to discuss this topic, and hope that I could give some good points, and also try to educate everyone around that burns in pediatric really severe and takes really huge huge size in the pie of morbidity, and unfortunately many cases are from accidents in the kitchen. So just really the parents should be really careful and try to avoid those.
Thanks for that, and we'll see you next month.
Thanks, Aebhric. See you and talk to you in next month as well.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, Corom, Corum.org.